to you guys that I'm not going to require you to memorize all of the details of this brachial plexus, but I would like for you to know how to give a sketchy outline of what we're talking about, okay? So the first thing, as part of your outline for the brachial plexus, is you should be aware that the brachial plexus includes information from these divisions of the spinal cord. So from C5 to T1, these are the portions of the spinal cord that feed the brachial plexus. Now, what do we mean that these divisions of the spinal cord feed brachial plexus? Why is that important? Well, here's the answer to that. Most of the muscles that move your upper extremity, most of the muscles that move the upper extremity, your shoulders and your arms, are innervated by nerves that come off of the brachial plexus from C5 to T1. So that's an important piece of information. So if you have a problem in the spinal cord, in the motor areas of the spinal cord between C5 and T1, you can expect to have problems in the muscle contraction for the muscles that move the upper extremity. Now here's the second thing that I want you to take away from this. It's on this side of the picture. There are 5 major nerves that are terminating nerves of the brachial plexus that innervate muscles of the arm. So I would like for you to know the names of these nerves, what their names are. I would like for you to know in general what they do. So I've got that typed for you on the slide. And I would like for you to be able to talk about where they can be located around the elbow. Now that's not exactly the way your book describes it, but that's a take-home message that can linger. So as a teacher, I want these pieces of information to linger. That is, later in your life, when you hear things talked about with nerves that control the arm, I want you to have something in your mind that lingers. Where are these nerves in my arm? So let's list them first, and then I'm going to show you a picture. We just looked at it. I'll show you a picture and give you some lingering pieces of information. By lingering, I mean you should remember these things forever. You're clinical people. You're talking about nerves in your arms. These are the names of the major ones and what they do. All right, so the first one on the list is the musculocutaneous nerve. It says here that it is for brachial flexion and lateral forearm sensation. Okay? So, what do I mean by brachial flexors? So the brachium is the humerus. That's the upper arm. So I'm going to flex at the upper arm with the musculocutaneous. So I can do that in 2 ways, right? So I've already learned that the deltoid does a little bit of this, although it's a major abductor of the arm. It does a little flexion because of its anterior attachment to the deltoid tuberosity. Okay? But there are other muscles that flex at the shoulder. And one of those attaches to the coracoid process and the arm. It goes from the scapula to the arm right there. So when it contracts, it flexes at the shoulder. So that muscle will help to flex at the shoulder. It is a flexor. There are other muscles in the arm here. The name of it I didn't say because I don't want you memorizing it. It is the coracobrachialis, but it's okay. The other muscles here in the brachium portion on the anterior side of your arm are responsible for flexion in the elbow. So to do this is to use the bicep and the brachialis, 2 muscles we've already looked at. So the bicep, remember, is attached to the rim of the glenoid cavity, passing through the intertubercular groove and to the coracoid process and the radial tuberosity. The brachialis is attached to the shaft of the humerus and the coronoid of the ulna. These are the 2 major flexors at the elbow. All 3 of those muscles, flexion here, are innervated by the musculocutaneous nerve. So let's look at it. Here it is on this picture. Here is the musculocutaneous nerve. So there's the humerus right there. The scapula would be over here, and this is the musculocutaneous, passing along the anterior part of the arm. Now the next observation here says the musculocutaneous is for lateral forearm sensation. And so if I look at this picture, I can see the musculocutaneous as it passes down toward the elbow, turns lateral, and comes out into the forearm. Okay, so the first nerve to learn as a terminating nerve is the musculocutaneous, and it's a flexion of the brachia, shoulder and elbow. And it turns lateral at the elbow. It is, in fact, the most superficial and lateral nerve in the elbow. So the first one to learn, as we work our way lateral to medial, the first one to learn is the musculocutaneous. This is musculocutaneous. This is musculocutaneous. All right? The second one on the list here is the median. The median nerve is responsible for flexion also, but in the anterior forearm. So it's going to pick up the pronator the pronator teres. You don't need to know that. It pronates and does some sensory stuff out of the lateral hand. Okay? So the median nerve is the next one on this list. Notice that the musculocutaneous and median both get information from the upper portion of the spinal cord. Now, let me point this out to you because there's some very famous neurological clinical manifestations of brachial plexus problems. And I know, don't panic on me. You don't want to know all this right now, but here's what you don't want to know. You don't want to know this for memorizing, for test purposes, to have to remember the details of. But listen, you do want to know this kind of stuff because if you're interested in clinical things, this is real. So if you have a baby that's pulled out by the head and you get major stretching of the head this way, or somebody falls off a horse or falls off of a motorcycle and lands on the side of their head and stretches this angle right here unnaturally, you can actually tear portions of the lateral cord here of the upper portions of the brachial plexus. This is a very famous neurological problem called Herbst-Duchenne syndrome. The Herb-Duchenne syndrome. Now, you don't need to memorize that thing, but there will come a time in your clinical life where you hear about this with problems with the contraction of the muscles in the shoulder and the arm related to that. This is an upper brachial plexus injury that is going to be related to problems in the muscles that pronate the arm, a locked pronation, and muscles for flexion here. So a major problem using the flexors. So the arm gets turned extended and pronated. Very interesting phenomenon in upper brachial plexus. This is the kind of thing that you can use to explain this. Now there are lower brachial plexus injuries also. Klumpke's is one where you would injure the lower portions of the brachial plexus, and that might be caused by a parent swinging their child around by their arms, stretching the lower portions of this brachial plexus. Now, whenever I see a parent doing that, I stop them. So my brother-in-law would love to do that with his boys, swing them around by the arms like that. And so I show him a picture of what it looks like in an individual who's had the lower portion of the brachial plexus torn by doing that. So you don't want to stretch this unnaturally, and you don't want to stretch out this way unnaturally to stretch portions of this plexus. No worries. This you need to know. The musculocutaneous is first on the list, median second, it does flexion. Now, when I say flexion here, I mean at the wrist. So if I show somebody this action, if I go like this or like this, they think musculocutaneous nerve. If they go like this, like that, flexion at the wrist, median nerve. So here's the picture of it. This median nerve passes essentially through the middle of the cubital fossa. It is actually slightly medial in relation to the medial epicondyle. So if you take your hand like this, hold your arm out like this, and you push right there, there's a bony knot. That bony knot right there is that bony knot. That is the medial epicondyle of your humerus. So if you roll over the medial epicondyle onto the cubital fossa, just roll over onto the cubital fossa right there, you are where the median nerve crosses the elbow on its way to controlling flexion in the forearm. Okay, here's the next one. The ulnar nerve here. Now you can see the ulnar nerve is also in proximity to the medial epicondyle. But whereas the musculocutaneous and median pass on the anterior aspect, the ulnar nerve passes posterior. So once again, with my arm out like this, that bony knot. If I roll anterior here, I hit median. So if you're doing an experiment in a laboratory, you've got a stimulator. You put the stimulator in the cubital fossa. What will happen? Stimulate the nerve in the cubital fossa. What happens? This happens, right? So now I'm going to take the stimulator and move it around to the back of the medial epicondyle. The question now is what will happen, and the answer is the ulnar also picks up two flexors. And you can see in this picture, back, you can see in this picture where the ulnar is going. It's headed out to the little fingers. Now, most people refer to this location where the ulnar nerve passes through the elbow as the funny bone. So if you hit your elbow on something, so if I walk by and I bang my elbow into something and it hits on the posterior aspect, what is the sensation that follows? Tingling. Where? Where? What fingers? In your pinky fingers, yes? Your pinky finger and part of your fourth. So the tingling is out here on the most medial aspect of your hand. That is ulnar. Where is the ulnar nerve? It's on the posterior aspect of the medial epicondyle. And it services two of the flexors for the last two digits. And so the ulnar nerve would see flexion here in digits 4 and 5. Median gets really the whole hand, but it's primarily digits 1 to 4 for the median. And you can see that on this picture as well. It picks up 4, 1, 2, 3, and 4 for the median. So you get this action for median. You get this action for ulnar. All right, the last one that I'm going to do, because the axillary is in the shoulder, is the radial nerve. The radial nerve is the extensor nerve. So I'm going to point to arm. I'll show you this one, then I'm going to point to arm, and you tell me nerve that does it. Ready? So this is musculocutaneous and median and ulnar. Musculocutaneous sensory. Now, all of this, the triceps, and all the extensors on the posterior aspect get radial. All of them get radial. Okay, so let's do function, right? Give me nerve name. Musculocutaneous. And if the deltoid gets axillary, you can also do a small component of axillary here. So this would be musculocutaneous primarily and some axillary. All right, how about this? Musculocutaneous. How about median? Ulnar. Radial. That's radial. That's radial. Extension at the wrist is radial. Okay, so let's do it with an experiment. So I have my little probe, and I'm going to deliver some current to the arm. And I deliver the current on the posterior aspect of the medial epicondyle. What happens? 4 and 5 will flex. I roll the stimulator around to the cubital fossa, and I stimulate here in the cubital fossa on the medial side. What happens? Flexion at the wrist, right? Most of the fingers, 1 through 4. Flexion, right? What if I move the stimulator over more lateral in the cubital fossa? This is the last piece of information. The radial is the extensor, but look at what it does in the elbow. It does pass behind the humerus to get the triceps, and it does pass, as you can see it bending here, it does pass to the posterior aspect of the radius to pick up all the extensors. So the radial nerve is for extension, and you should think about the radial nerve as being on the posterior side of your arm. But that's not where it is in your elbow. In your cubital fossa, it's on the front. So it takes an odd little turn here, behind the humerus, comes across the cubital fossa, and then passes back to the back again. The radial nerve is on the anterior side. So if I take the stimulator and I stimulate on the medial side, I get flexion. If I take the stimulator and I stimulate on the lateral side, I get extension. Does everybody see that? So know where the four major nerves of the brachial plexus are in the cubital fossa and what they do, which I have just listed for you. All right. Now, let's go down to the legs. We'll pick up some bones in the legs, and then I'm going to talk about the nerves down here. There's a lot of information here in the lumbosacral plexus, and I'm not going to do any more with it than I've done with the cervical and brachial. But a student ought to leave anatomy, a test 2, being able to talk about at least an outline in general terms with some of the nerve names for these four major plexuses. All right, so this is the leg bone here. This is the femur. And this part of the femur, the fovea capitis, and the head of the femur articulate in the acetabulum of the hip. Now, I would like to say a little bit more about that articulation. I want to do it a couple of times. Okay, so today I'm teaching you the name of the bone, the parts of the bone, and in general terms talking about its articulation. But I'm going to do it again as we talk about the muscles that are on the legs. On Wednesday, we're going to do this again. So this is your first time through it. The fovea capitis is a little indention in the head of the femur. And the head of the femur, as you know, articulates in a deep fossa in the hip bone called the acetabulum. Now there is a ligament, in fact, that attaches here to the fovea capitis and into the acetabulum. It's called the round ligament. There's several of these in the body. There's another important one that's attached to the liver, and I don't know why we can't come up with some different names, but you don't have to know the name of it, but I'll tell you about it a little bit to get you interested in it. The name of that ligament is the ligamentum teres, and the blood supply into the head of the femur passes along a blood vessel that goes into the head of the femur there with the ligament. Now, if you were to cut everything else away so that there was nothing else holding on to the head of the femur, as it turns out, there's 3 big ligaments that hold the head of the femur in place. You learned the name of the ligaments that hold the shoulder in place, but you don't need to memorize these because their names are obvious. What are the names of the 3 bones that make up the hip? Ilium, ischium, pubis. All right? So there are ligaments that come from all 3 of those components that hang on to the femur. You want to name them? Ischiofemoral, iliofemoral, pubofemoral. Good. So big ligaments that hang on to this thing. And those are the ones that really stabilize this head. Now, does it really need a lot of stabilization in comparison with the shoulder? It does not. Why not? A deep fossa. The acetabulum is a deep fossa. Right. Now, if you were to cut those away, cut those pieces away, and just have the head of the femur in the acetabulum, this would be the only thing holding it there, this ligament with the blood supply into the head. Now, the ligament itself doesn't appear to have any function at all because in your body and mine, the ligament is not tight. It's loose. So you could actually take the ligament, you could take the head of the femur, and you could pull it out about ½ an inch out of the acetabulum, and it would be hanging on to that ligament. Now, a ligament that's loose like that does not really offer any stability. You see that? It would have to be tight in the acetabulum for it to be an important piece holding it. So no textbook will tell you that it's important. But how many of you guys were alive and saw arguably one of the most famous injuries in all of sports history when Bo Jackson was tackled? Did you say that? Is that what you said? Oh, you said a different one. That's not what you were thinking. One of the most famous tackles in all of history, when this unbelievable athlete who apparently could play Major League Baseball and be a top 10 player in the major leagues, there and be the top running back also in the NFL. He was a running back for Auburn University, and so he's in the NFL. He has this whole series of commercials. He's making bazillions of dollars, and he gets tackled, and it looks a little awkward as he's being tackled. And he gets up and he's hurt. Nobody really thinks too much of it. But it ended his career. Do y'all remember this? Do any of you remember Bo Jackson, his career? It ended his career. And although the lawsuits really didn't go anywhere, as far as I know, maybe there were settlements made, it was actually incompetence that caused him to lose his career. You think, well, he tore his ligaments. Well, as it turns out, we can build ligament things in people's bodies that are better than the originals. I mean, the ACLs that they're doing now in people's knees, I mean, after the surgery, their knees are stronger than your knees are originally. These guys, ACL injury is no longer career ending. But this ended his career, and people wonder why. And the answer is because of this location. The head of his femur was actually, the ligaments were stretched such that it actually tore that ligamentum teres. And in doing so, it broke off the blood supply to the head of his femur. And nobody saw it in the original x-rays, which means that it went on for days and days and days with no blood supply to the head of his femur. So what actually happened was the bone degenerated, and that is what ended his career. If the surgeon, after the inflammation was gone in the first couple of days, had gone in and repaired the artery that runs with the ligament to the fovea capitis, Bo Jackson, in my opinion, probably would have set some records in baseball and football that no one would ever do again. So I always tell the story, it gets people's attention. The fovea capitis, when you look at it on the femur, you'll think about it differently now. It's an attachment spot, but really, it's an important spot for the entry of blood supply to the head of the femur. There's a ligament there, but that ligament doesn't do anything except support the blood vessel passing into the head of the bone. Now, the rest of the bone here, as you work your way back, is this portion of the bone is called the neck of the bone. And this also has an important story, an interesting story that'll help you remember as you work your way onto the body of the femur. This neck of the bone is really referred to commonly by people as the hip bone, whenever they refer to older people who have osteoporosis who have broken hips. So you probably have relatives, you know someone older, normally female, who has suffered for years with osteoporosis, the degeneration of the bony matrix. And so their bones become very brittle. My wife's grandmother, she would be 103 now, if I'm counting right, if she had lived. But many years ago, we were visiting them, and she was sitting in the chair, and she stood up, and when she did, the right side of her body collapsed like this. She wasn't in horrific severe pain, but she could not move her right leg with her hip or support her weight. So took her to the ER, she broke her hip. They had to do surgery on her. They broke her hip? Is that what happened? No, that's not what happened. The neck of her femur broke. So this is a thick portion of the bone, and the truth is, as I stand here, the weight of my body sits on two bones. The weight of my body sits on the sacral promontory, S1, the body's true center, and it sits on the neck of my femur. The weight is not on the hip bone, the weight is on the femur, on the neck of the femur. And so that's, when you say broken hip, that's what you mean. Now, I had a student years ago who I told this story to. He worked for an orthopedic surgeon. He's since gone to take a job up in the Midwest. Great kid, and they were doing surgeries, and there was a lady who came in, and they had put on her a titanium reinforced angle. with 2 screws on the top and 2 screws on the shank. So it was like this. They had actually screwed this titanium piece into her bone here, and then screwed the other part of the titanium piece in here to support the neck of her femur. And the titanium piece was not holding up the weight. And so they had to go in and do surgery, and they actually cut the entire proximal end of her femur off and replaced the whole piece with titanium. And he knew that I always tell these stories about hips in my class, and so he asked the doctor if he could have the titanium insert. Now, I didn't bring it to class with me today. I have it in my office if you'd like to see it. It is striking to think that that thing was attached to a woman's bone in her body. Now, of course, they cleaned it and autoclaved it and all that, but it shows you the many procedures and techniques that are used. One of them that is used to support this place in the human body. It's a really important spot. Okay, now just like the humerus had a greater tubercle and a lesser tubercle, the femur has a greater trochanter and a lesser trochanter. Now, these are the kinds of things I like to ask on an exam. I like to say, where is the lesser tubercle in relationship to the greater tubercle? And the anatomy term I'm looking for is, where is the lesser tubercle in relationship to the greater tubercle on the humerus?
Inferior.
It is inferior.
And posterior.
Which one is posterior, the greater or the lesser?
Greater.
The greater is posterior, right? The lesser tubercle is anterior, right? And what muscle attaches to the anterior? It explains shoulder dislocations. There's only one on the front, and what is it? The rotator cuff on the front is the subscapularis. That's the one on the front, okay? So on the hip here, on the femur, where is the lesser trochanter in relationship to the greater trochanter? Okay, it's inferior, that's true, and it's medial. That's the same description. It's inferior, it's medial, but what else? Is it anterior or posterior? It is posterior, exactly. So the knots on the top of the humerus are lateral and posterior and anterior and inferior. The knots on the femur are lateral and posterior and posterior and inferior. Right, the lesser trochanter is actually an anterior knot on the proximal end of the femur. Now, sorry, I said it backwards. A posterior knot on the back of the femur. Now, if you continue down from the lesser trochanter, there's a little knot that's actually hard to distinguish in the lab called the gluteal tubercle, where the gluteus muscle is attached. There's 3 of those. We'll look at them. And then there's a line here extending down the posterior aspect of the femur called the linea aspera. Now, the linea aspera, this linea aspera is, right, things that you can remember forever. The linea aspera is the portion of the femur that adducts. The linea aspera is the portion of the femur that adducts. The muscles that are attached to the pubic bone that are responsible for adduction, that are named adductors. Adductor brevis, adductor longus, adductor magnus. They all go to the linea aspera. This is the adduction bony piece of the femur. Now, the other surprising thing about the linea aspera, students, when I teach them the attachments, and they're on the slides coming, the other surprising thing about the linea aspera is this is also an attachment for 2 of the quadricep muscles. Now, when I teach students quadriceps, I tell them, you think quadricep, front of the leg. You think hamstrings, back of the leg. You think quadriceps, femoral, lumbar plexus. You think hamstrings, you think sciatic, sacral plexus. So we're going to do that here coming. I have it on the next 2 slides. That's what you're supposed to think of. But this is surprising. The largest mass muscle on the front and medial side of your leg is the vastus medialis. And you would think that that large muscle, being in the anterior compartment, would have all anterior attachments. But it actually loops to the back to attach to the linea aspera. So there's a large muscle here on the front that's attached on the back. The one on the lateral side, the large quadricep muscle on the lateral side, the vastus lateralis, same thing. You think, well, that one would have all anterior attachments. But it doesn't. It actually has also a linea aspera attachment. So on the sides here to the linea aspera. So can you say that this part of the bone is important? The linea aspera. The mass of your leg flesh between your knee and your hip, most of it is attached here to the linea aspera. The largest massive muscles, the adductors and the quadriceps, are both attached to the linea aspera. It's a very important line. All right, at the end of this is the, speed up, Wade. The end of this is the distal end are the condyles. So there's a lateral and a medial condyle and an intercondylar fossa and a lateral and medial epicondyle here on the distal end of the femur. And what we're going to do here, after I teach you the plexus stuff, what I'm going to do here is I'm going to blow this up like we did the shoulders. So in the same way you can construct a shoulder when I finish on Friday, you're going to be able to construct a knee as well. All right, so let's do the plexuses. A reminder is before we do it. Reminder, when I say plexus to students, they're supposed to think about the spinal nerves. And when I say cervical plexus, they're supposed to think C1 to C5. And when I say brachial plexus, they're supposed to think C5 to T1. Now, the nerves between T1 and T12 do not fit the plexus descriptions. These are called the intercostal nerves or the thoracic nerves. And they're paired just like they are higher and lower in the cord, but these nerves come off in a segmental fashion. So I love this because you don't have to memorize them. All you have to do is to be able to locate the spinal segment. They come off in segments. Now when you get to the lumbar areas of the spinal cord, this lumbar enlargement, you'll have lumbar nerves, L1 to L5, and sacral nerves, S1 to S5. And these nerves are part of 2 more plexuses. Now some books actually include this as 1. We're going to split it up into 2. That's the way Merriam does it, the text that you have online. And so we're going to talk very briefly now about the lumbar plexus and the sacral plexus and what they do. So if I go up here to my neck and stuff, and I say, tell me, what is the name of the plexus that feeds these muscles that move my head around here? You would say cervical plexus. And I said, what is the name of the plexus that does all of this? You're going to say brachial plexus. And then now you can name some of them, right? Give me names. Musculocutaneous. Median. Ulnar. Radial. Radial. Okay, so major nerves of the brachial plexus. Okay, so let's do that with the lumbar plexus. So this shows you all kinds of information that you don't have to know. All right, but I want to teach you the major nerves of the lumbar plexus. So first of all, we say the lumbar plexus extends from L1 to L5. But really, you can describe this entire plexus really with 2 nerves. These 2 nerves are the femoral nerve and the obturator nerve. Y'all seen that word obturator before? I wonder what passes through the obturator foramen. You see where this name comes from? Okay, so the femoral nerve and the obturator nerve here. All right, so you can see the obturator nerve here clearly. This obturator nerve here clearly is coming down the medial aspect of the leg. the medial aspect of the leg. The rest of the front of the leg here, you can see is supplied by what we call the femoral nerve. So the femoral nerve supplies these muscles in the anterior compartment. The obturator nerve supplies these muscles in the medial compartment. So, as I stand in front of you, these muscles here, so if I say musculocutaneous and median here, what I say here is femoral. And what I say here is obturator. Good. Now, let's not worry about the spinal cord segments. You'll just remember, these both actually get mostly 2 to 4, but you'll remember lumbar plexus L1 to L5 does this. So L1 to L5, take-home message. Femoral and obturator, take-home message. All right, here's the sacral plexus, and you see it has extensions from even into the lumbar. This is why some of them include it. But let's say, generally speaking, for sacral plexus, fibers from L5 or S1 through S5. So L5 to S5 is a good spread for the sacral plexus. Now, the major nerve of the sacral plexus, just one of them, is called the sciatic nerve. And the sciatic nerve, I don't have it typed up here, but I'm going to tell it to you anyway. The sciatic nerve is made up of 2 nerves, and they are the tibial and the common fibular. All right? So on the front I had femoral and obturator. On the back I have sciatic. The sciatic nerve comes out of the sacral plexus, and the sciatic nerve is really 2 nerves. It is tibial and common fibular. Now, the tibial nerve is responsible for the hamstrings. 3 of the 4. So 3 of the 4 hamstrings, you don't know their names yet, but this is the semitendinosus and the semimembranosus and the long head of the bicep femoris. So I'm going to show them to you. The motor input to the hamstrings, upper leg control, right? So the quadriceps do extension, the hamstrings do flexion. So the 4 big muscles on the back, 3 of them are controlled by the tibial. The common fibular nerve, on the other hand, is primarily it is a lower muscle controller. It is a crural muscle controller. That is not to say the tibial doesn't do some down there, but the motor control of the common fibular only picks up one muscle at the top, and it is the short head of the bicep femoris, the short head of the bicep femoris, the other muscle of the hamstring. Now, I want to say all that again, but with pictures. So, let's start this story at the top and work our way down. So here's what I'm going to do. I'm going to introduce to you a clinical thing to get you interested in the front of the leg. That's what this is. This is not in your book. You can hear me saying these clinical things to you all the time. We've mentioned upper and lower brachial plexus injuries today, and now I'm mentioning something else. Okay, I'm not going to make you learn Klumpke's or Erb-Duchenne syndrome. True. But this one is clinically important enough that I think it should be in your book. I dare say there won't be anybody in this room who will ever work around clinical situations that won't be introduced to this at some point. You need to know this. I think if you have a clinical A&P, somebody ought to tell you about this. All right? So this is the all-famous, the all-important anatomical location called the femoral triangle. The triangle itself is bordered on the upper portion by a ligament called the inguinal ligament. Now let me attach it for you. This inguinal ligament is attached over here at the anterior superior iliac spine. Can I say that? Can you pick up a hip bone and find the anterior superior iliac spine? This is why you were supposed to do this in the laboratory. The anterior superior iliac spine, and it stretches across this way medially to attach to the pubic bone. Close to where the cartilage is, the little tubercle there on the pubic bone. So from the anterior superior iliac spine over to the pubic bone, there's a thick ligament, and it can be easily palpated clinically, the inguinal ligament. You can feel it in the inguinal region. Now, to the lateral side of the femoral triangle is the sartorius. This is the longest muscle in your body, the sartorius. And I have another picture of it coming. The sartorius also attaches to the anterior superior iliac spine. And it comes across the front of the leg. It is the most superficial muscle. It goes right across the top of your quadricep and attaches to the epicondyle of the tibia. Just below the epicondyle of the tibia, it actually extends across the knee joint to attach to the lower leg bone, the sartorius. So the sartorius runs angular like this, and it forms the lateral portion of what we call the femoral triangle. The adductor longus. Have you heard adduction already today? Where do you think the adductor is going to be attached? Where? Where is it going to be attached on the femur? On the linea aspera, you bet. So the adductor longus here, you can see extends down from the pubic bone down to the linea aspera. These two muscles in this ligament form a triangle, and within that triangle, which can be palpated easily, is an easy access point to the nerve and blood supply to the legs. And the most clinically significant container within this femoral triangle is this blood vessel, the femoral artery. So today at both hospitals, there have probably been 24 procedures where surgeons have been accessing the femoral artery via the femoral triangle. This is the #1 entry point for procedures in which stents and other work is done in the coronary arteries. This is where they go, into the femoral artery. So you see what I mean by important clinically? This is a really important location for people who are going to have heart things done. Okay, now, I'm hoping I've got your interest in the front of the leg. So when we get together on Wednesday, I'm going to finish the front of the leg with the muscles, and then I'm going to do the back of the leg. We'll cover the lumbar and sacral plexus again, and then I'm going to do the lower leg. And then we're going to finish this up on Friday, right? Because you got a test on Monday, right? Okay, so time to get busy.